medicine at Case Western Reserve University. He is a frequent and very well-known lecturer, both nationally and internationally, on the topic of high-value care approach to blood management, as well as transition of care of medically complex young adults. Um, Dr. Auron really has a very big, large, really very impressive resume, but I just wanted to highlight a few points here. He is the Quality Improvement Officer for the Department of Hospital Medicine at the main campus Cleveland Clinic, and he is the Enterprise Medical Director of Blood Management, and he's an associate editor of the Cleveland Clinic Journal of Medicine, and he is recently elected as the American College of Physicians Governor for the state of Ohio. So Dr. Auron, we're extremely excited to have you today, and I'm going to pass it to you.
Well, thank you, Dr. Youssef, for the kind introduction. I truly cherish your friendship and collegiality. We miss you here in Cleveland, but I'm sure that you now have a nicer, newer colleagues and also better weather. And so at least we can communicate always and maintain the long-lasting friendship via the distance. So it is an honor to be here with all of you here at the University of South Florida. It is a true joy and pleasure to speak to you. And for me, it is a journey to ensure that we all have awareness of the high-value approach to blood utilization. I have no disclosures to state for this meeting. We'll have a brief outline of what we're going to be speaking about. We'll focus on the physiology for anemia, the evidence for transfusional medicine, and blood utilization, what is the adverse effects of it, which supports the protocol for anemia optimization. And we will conclude briefly speaking about FFPs and platelets. So this is a case, basically a patient who has a cancer, colon cancer, needs a colectomy, hemoglobin is 8, and in order for preparation, the anesthesiologist ordered to give a unit of blood. The rationale is that patient needs blood for optimal oxygen delivery. The disagreement with the anesthesiologist is based on that the threshold for transfusion should be less than 7. We could optimize preload or oxygenation. So let's talk about it. First of all, this slide, and you can get a screenshot of it. This is perhaps the single most important slide and topic I discuss with my residents every single time in both internal medicine and pediatrics. So I explore here. I want to use I explore here how the oxygen delivery will be the product of the cardiac output times the arterial content of oxygen. What we have to do is to dissect each one of these contents. The cardiac output will result as a product of the stroke volume times the heart rate. And the stroke volume will be determined by the preload, afterload, and contractility. If you dissect things as what determines preload, venous capacitance, but when you ask the resident, well, how does the vein get full of blood? And then everybody gets a stare to the blank stairwell. You drink water, right? That water gets absorbed, right? But to drink water, you need to have a fully hypothalamic function, so you get thirst. You have osmoreceptors, chemoreceptors. So you drink water, but that water has to be absorbed, right? So you need to have a functional enterocyte. And then you need to have a functional mesenteric and splanchnic circulation that goes to your kidney. And then we start discussing about all the different hormones that work, right? The renin, angiotensin, aldosterone, arginine, vasopressin, and so for sympathetic, parasympathetic system. All of that stuff is going to determine that. And then, of course, all the hematopoietic system that will make the blood. Afterload will be all the previous components. I mean, the renin will have vasoconstrictor ability and angiotensin, the same as arginine vasopressin. Vasopressin is a vasoconstrictor, the same as the sympathetic system, the same as the thyroid hormone regulating all this metabolism, as well as steroid and so forth. And contractility, the same thing as above, but also the anatomy of the heart and the cardiac myofibril, the mitochondrial density, and electrolytes and so forth. So when we speak about each one of these things, it helps us to gain more awareness about things that we'd rather optimize. I mean, why do we check a BMP? I mean, well, we want to ensure that electrolytes are fine. because of the impact on any of this function. And then the arterial content of oxygen, well, will be determined by the saturation times 1.34 with the amount of oxygen per gram of hemoglobin. When we look at the saturation, then we can look at all the causes for hypoxemia. VQ mismatch, shunt, diffusion problem, hypoventilation, low FiO2, and so forth. So we can focus on all these things. I mean, what can cause VQ mismatch? Could be atelectasis, could be a pneumonia, could be APE, what's the reason for a shunt, and so forth. And so the more we think about it, the more we can optimize other things. Why we ask the patient get out of the bed and walk and take a deep breath? Well, because we want to avoid atelectasis. Why? Well, to avoid hypoxemia from VQ mismatch. And then, in regard with hemoglobin, well, first of all, I cannot fix a thalassemia. I mean, I don't do genetic therapy, okay? I don't fix genes. That we cannot do that. But I can fix the things that are not determined by genetics. I'm not fixing thalassemia. I'm not fixing sickle cell. I'm not fixing hereditary spherocytosis or any erythrocyte membrane problem. But I can definitely fix iron deficiency, B12 deficiency, folate deficiency, zinc deficiency, copper deficiency, fix the nutrition. So when we look at these slides, it seems a little bit intimidating, but it is not. Just very quickly, the absorption of iron is going to go from the ferric side reduced to ferrous side. The divalent metal cotransporter brings it inside the duodenal enterocyte. Ferroportin brings it to the blood side, and hepestin will oxidize it back to ferric state. That's taken by the transferrin. One molecule of transferrin takes 2 molecules of iron. 1 molecule of ferritin takes 100 molecules of iron, just for comparison. Now, the fasting will be copper and zinc dependent, and when we have copper or zinc deficiency, that will impair iron absorption. It's important to reflect that when you have refractory iron absorption and the patient does not have celiac disease, the patient does not have malabsorption, always think whether you could have copper or zinc deficiency. Now, in all the inflammatory states, it's going to lead for the liver to produce hepcidin. Hepcidin will always block the absorption of iron from the enterocyte and also block the release from the reticuloendothelial system. Now, interestingly, when we supplement iron enterally and we give the iron more than once a day, even more, we give it daily, we paradoxically increase the production of hepcidin. Therefore, we have gone now from giving daily iron to give every other day. We'll speak about that briefly later on. Now, we have both absolute iron deficiency, when definitely there's significant bleeding, there's no stores of iron, ferritin is very low. We also have functional iron deficiency, when we do have very elevated ferritin level, mostly in the state of inflammation. What happened with the functional iron deficiency is that will also lead to mitochondrial dysfunction. Interestingly, in patients with heart failure, when we supplement IV iron, we actually improve the myocardial efficiency. Actually, when we do electronic microscope, we actually see a better rearrangement of myofibril and also increased density of the mitochondria in the myocardial. So all of the above will be the answer for these. So we hold the surgery, we evaluate hematinics, and we replete them parenterally. Patient got IV iron, IMB12, hemoglobin comes back at 11. What happened after the hemoglobin went up? Well, there's decreased transfusional needs. Could there be decreased morbidity or mortality? So let's just reflect. This is Asian population, but it basically reflects all population in the world. There's an aging surgical population, and the older the patient are, the higher prevalence of anemia. Now, in this cohort of 227,000 patients, where 70,000 have anemia, the anemia by itself conferred an increase of 35 to 42% of morbidity and mortality. Now, even more, this is cardiac surgical patients, where you have anemic patient and non-anemic patient. They divide both of them into patients with iron deficiency and non-iron deficiency. Even among the non-anemic patients, those who have iron deficiency, have an increased rate of all the adverse outcomes, mortality, serious adverse event, or major adverse cardiac events. So I was telling you in the functional iron deficiency, the patient with heart failure, they have a change in mitochondrial density in the myocardiocytes. So it may be relating to this. Now, from the MET study, among the patients who had anemia, they have a decrease in the maximum oxygen uptake and a decrease in the anaerobic threshold. So this is really interesting because based on this, when we do the DAS index, we ask the patient question, but we don't know what hemoglobin is. So the problem could be that the patient could be also anemic, and you are affecting all of these parameters. So it may not be reflective of the patient real state. Now, this is from our colleagues at Cleveland Clinic. They have found, means is something you will be hearing more and more and more. This is myocardial ischemia in non-cardiac surgery. The means, we don't know what to do with means because the patient just had a surgery, the risk of bleeding with thrombolysis is high, the risk of bleeding with anticoagulation is high. So sometimes we have to do, should we stress those patients? Should we do a revascularization? What should be the best management? Sometimes we just do medical management. But the interesting thing is that among the patients whose hemoglobin in the post-op day 3 goes below 9, actually below 10, but 9 is a inflection point, they start having an increased risk of means per gram of deciliter to about 30 to 35%. So what we can take from this is that your patient who have anemia preoperatively, going for elective surgery, try to optimize them and rise that hemoglobin as high as you can. Go above 14, 15. I don't know why we are so afraid of going high on the hemoglobin. It's very interesting. The more I give this lecture, the more people ask me questions, what should be the highest level? If we are causing any risk or damage to the patient, we're not going to cause stroke by giving an hemoglobin of 15. Just let me tell you. What happens is if the patient has hemoglobin of 15 and they bleed 5 grams, they will never reach, they will just reach 10, but they will not be in this area of where the risk of means will happen. So let's try to optimize. I know it's hard. The problem is patients get evaluated for surgery just almost immediately, and we don't have time to optimize. Now, this is something to think about. Now, and this is something that I added based on a presentation I gave in Peru 2 weeks ago. And the question was about what happened with a patient with subarachnoid hemorrhage. And the patient who have anemia, and they're going to have an increased risk of transfusion, but they also have an increased risk of mortality. So in the Cleveland Clinic, we do not, here's the deal. In the Cleveland Clinic, we are very compartmentalized. I do not manage stroke patients. I do not manage cardiac surgical patients. So please don't ask me those questions. But I was asking Peru about this. So I put this expertise, and I have done now some research. In subarachnoid hemorrhage, is the patient at the time of the subarachnoid hemorrhage, they have an hemoglobin less than 10, they have an increased risk of mortality of transfusion. So the patient that have stroke from hemorrhagic stroke, they need to have hemoglobin above 10. So that's a very different subset of patients. We do not engage in blood management with them. So some of these patients, when they have aneurysms, we coil them, we embolize them, and also the neurologists aim to improve the hemoglobin as high as they can. So in case they bleed, they don't have this level, and they actually transfuse this patient. So we don't do blood management. In this case, in subarachnoid hemorrhage, your blood management needs to transfuse to keep them hemoglobin above 10. So I want you to bring that up because this is something that is not what I manage every day, but I want to ask this question, so I pass this wisdom forward. So what does the Society for Advancement of Patient Blood Management state? Elective surgery is elective. Elective surgery is not the patient one that procedure just done because it's elective. If you can wait 6 months, you can wait a year. It's not life-threatening. Just optimize the patient hemoglobin. Please change the workflows. We are still not doing this in the Cleveland Clinic. We are still seeing a lot of patients who the orthopedic surgeon know that they are going to change that hip in 6 months or a year. And there is no assessment for hemoglobin. There is no optimization. Primary care physicians, they write in the note, anemia stable. Anemia is not normal. Anemia is not a disease. Anemia is a consequence of an underlying problem. But we don't take the time to evaluate for that. Please try to evaluate that and optimize it. So in this case, all of the above will be the answer. So I have told you that anemia is associated with increased morbidity and mortality. Now, what should be the best cutoff value of hemoglobin? Now, we used to transfuse with hemoglobin of 10 or a crate of 30 based on studies in dogs done by these two OBGYN surgeons, Adams and London, in the 1930s and published in 1940s, with no evidence in humans. This led to an indiscriminate use of blood. Each unit of blood costs from $500 to $1,000. And this is based if they are leukoreduced, they're radiated, and so forth. The blood management processing is very expensive. Blood is expensive. So now, again, I have told you a cutoff value of hemoglobin of 10 will be a very different ballgame in a subarachnoid hemorrhage. That's a different ballgame. Very different ballgame in sickle cell patients who need to go to surgery. The TAP study in sickle cell patients, they suggest that hemoglobin of 10 preoperatively provides best outcome. But that's not what we are going to focus in terms of blood management. We focus on the other patients. So the NIH stated in 1988, hey, we are overwhelmingly using blood. Most of the patients with hemoglobin of 10 or crate of 30 really needs blood transfusion. It's often level less than 7 that will be more often need blood. So this led to all the normovolemic hemodilution studies, where those patients was bled from hemoglobin of 12 down to 8. They got IV fluids replacement with normal saline, and they were able to maintain in different clinical contexts the coronary artery disease that were well treated, assessment with echocardiogram, and elderly patient with no problem, plus other population, but that kind of reflect kind of the same as the normal population. And they would be finding there were appropriate increase in the cardiac index. There was no major changes in the EKG. There was appropriate change increases in the oxygen extraction. So they're like, well, the patients are tolerating this. This led to studies in younger patients to make the blood, the bleeding down to hemoglobin of 7. And they did a mathematical operation. And they found that the velocity of, and the speed of reaction for mathematical operation with an hemoglobin of 7.2 was the same as an hemoglobin of 14. But when this hemoglobin came down to 6 and 5, there was a lag in the reaction time. And when these patients were transfused back to 7.2, there was a recovery in that reaction time. So this is a seminal study by Dr. Weisskopf that basically led to the practice that we have now with an hemoglobin of 7. So we found that how can this compare with normal population? I mean, we found that hemoglobin of 7 is tolerated, but these are healthy patients, healthy volunteers. We have elderly patients, well-managed on beta blocker. But often, some of the CAD patients we see, they're still smoking, they are still having uncontrolled diabetes, the compliance is not ideal. And so we have the real patients. So this led to trials, randomized controlled trials in large populations. And we have, if you want to memorize one thing, just memorize the TRIC trial, TRICC. That's the only thing you need to know. And basically, these are cardiac, medical ICU patients, very sick patients. And when they were transfused with an hemoglobin of 7 or 8, in this case, it's a restrictive threshold, versus higher threshold, those patients who were transfused with an hemoglobin of less than 9, they have worse outcomes. But then we have other population. We have GI bleeding, we have shock patients, we have traumatic brain injury, and the higher threshold, they have the same outcome in some of the cases worse than the restrictive threshold. We have the cardiac surgical patient with active cardiac risk. This is the focus trial in elderly orthopedic surgery with high cardiovascular risk. They were able to tolerate an hemoglobin of 8. Now, one of the caveats with the focus trial is that now we know something we did not know in 2011, which is a means. So now, so how can we put this into context? So it is important to understand that these patients were able to tolerate hemoglobin of down to 8, but they were not assessed for means. So probably more knowledge will be coming upon. Now, even more recently, in a patient with AMI, we have the reality trial that it show that in AMI you can have a restrictive threshold of hemoglobin of 8, and they have the same outcome as a higher threshold of 10. What do the guidelines say? So for most patients that are hemodynamically stable, an hemoglobin of 7 is appropriate to consider transfusion, not to transfuse, to consider transfusion. You may still optimize. I have discharged patient from the hospital with hemoglobin of 6.5. I mean, if we have to optimize nutrition, minimize bleeding, we control the bleeding, we can do that and just follow up as an outpatient. We need to treat the patient, not the number. Now, if you have active surgical patient, pre-existing cardiac disease, well, you could have a hemoglobin of 8. Now, this does not apply for acute coronary syndrome. However, just realize about the reality trial that hemoglobin of 8 was tolerated in acute AMI. Also does not apply in patients with chemotherapy and chronic transfusion-dependent anemia. Sickle cell patients that are going for surgery, you may want a cutoff value of hemoglobin of 10 before the operation. So continuing, we have a patient that is coming to our service. She had a hysterectomy, has already required 3 units of blood. Hemoglobin is 7.1. Iron stores are low. What should we do? Consider this a moving target and transfuse, replete hematinics, evaluate for source control. So the question is, what is the number of units that you need to harm a patient? So in this different population, this is European ICUs, thousands of patients. This is a very large database of the National Surgical Quality Improvement Project from the American College of Surgeons. This is the premier claim-based database. In all of them, using 4 units or more than 4 units, increased mortality, increased risk of infection, increased length of stay, increased risk of AMI or stroke. So when I get a patient on my service, the patient has been already in the hospital for many months, which is not unusual at Cleveland Clinic, or patient is coming from the ICU, from a prolonged ICU hospitalization. One of the things I look with my team is how many units of blood has this patient received so far. If they have received 4 or more, we let's see what patient may be bleeding. Let's assess what studies have been done. Let's minimize transfusing this patient. And I'm always very cautious. Be careful. The more we transfuse this patient, this high risk of mortality, going back to the ICU, getting a stroke, AMI. And some of my residents look at me with skepticism. And unfortunately, I have received several patients with very bad persistent bleeding, requiring more than 4 units of blood, and these patients have had really bad outcomes. And so we have to be cognizant that if they have received multiple transfusions, especially 4 units or more, aim to minimize transfusing the patient. Now, if they're actively bleeding, it is what it is, but you have to have a discussion with the patient about goals of care. Now, among the risks associated with transfusion, I often listen from my trainees when they're asking for informed consent. They are explaining about viral infection. The risk of a viral infection is the same as crashing in an airplane, the same as getting hit by a lightning. It's really, really, really low. It's pretty much non-existent. What you have to really worry about is about transfusion-associated circulatory overload, TACO. That's what we have to. I have seen so many elderly patients get 1, 2 units, and nobody even think about giving some furosemide, some diuretics. I mean, this is so common, and we overload our patients. They have very stiff vessels. They have arteriosclerosis. They have stiff ventricle with heart failure with preserved ejection fraction. I mean, most of our patients have no tolerance to fluid challenges. So we have to be very cognizant of the risk of transfusion overload. So in this case, repleting iron and evaluating for source control will be the best next steps. So I have told you that anemia is associated with worse morbidity and mortality. Blood utilization as well has worse poor outcomes. So therefore, we should aim to minimize transfusion. How can we do that? Well, this is a very nice algorithm published 2 years ago in Anesthesia and Analgesia. And basically what they found in pre-op patients is evaluate any source for bleeding, and the most common cause of nutritional deficiency that can cause anemia is iron deficiency. So you can memorize this. Transferrin saturation less than 20%, ferritin less than 100, or reticulocyte hemoglobin concentration less than 30%. When we have any of these, we have iron deficiency and we can replete iron. Elective surgery, we can give it over time, ideally oral iron every other day for months, especially if they are not actively bleeding. They're actively bleeding. If there's risk for bleeding, we need to do endoscopy. If they don't have iron deficiency, we look for B12 or folate. If they are normal, then we look whether there's reticulocytosis or not. And if there's no reticulocytosis, then we can look at either chronic kidney disease or chronic inflammation, and then we can address that. I mean, does the patient have a myelodysplastic syndrome? Why is the patient having anemia? We often tend not to look into there. Now, the GI guideline that were also published 2 years ago now, they recommend to do bidirectional endoscopy, upper and lower endoscopy. If we don't identify it, just start a trial of iron replacement. And before if there's persistence, then we can do the capsule, but they do not recommend to go straight to capsule. Let's rather replete iron first. Now, when it comes to parenteral iron, there's a lot of fear about using parenteral iron across the board. I mean, I was trained, I did 8 years of residency, 4 years in Mexico, 4 years here. I was training both of them not to use IV iron. That IV iron was terrible, that caused a lot of harm to the patient, that was not a good and safe thing to do. So basically, there's a wealth of evidence, millions of patients. The risk of hypersensitivity reactive series is less than 1.7%. The safest profile happened with iron sucrose. And in this very nice study of 13,000 iron infusions, most of the infusions were able to be resumed safely. Now, this will be the clinical state or clinical scenario where you could reinfuse. Fish vein, which patients have some flushing and truncal myalgia. Often patients may be having some flushing, they feel, oh, I feel warm, but they are fine, they're breathing okay, they get some anxiety. And what do the nurses do? Stop the iron, they label iron allergy. And then we condemn the patient to get blood transfusion. Mild localized cutaneous manifestations that not hives, not wheals, moderate some nausea, abdominal cramping, hypotension, tachycardia. They don't have bronchospasm, they don't have airway abnormalities. When you have these, I mean, you could say that a fish vein and mild could be perhaps what you could do. I mean, remember, you can use the data in the safest way you can do. I see a fish vein reaction. Often patients say, "Oh, I'm feeling warm." Okay, they're breathing okay, it's starting fine, pulse ox is okay, they have no rashes, they have no wheezing, pulse intensity is appropriate, but they get anxiety because they feel warm. And the nurse, they tell the nurse just stop the iron, reinfuse at half of the speed. Often they're fine, or you can change the preparation. But don't stop the iron and don't label the patient as allergic to iron, because that becomes a problem, and then patient gets transfused rather than optimized. Now, so I mean, we can see that most of the patients that that have infusion response, even when they get a test dose, is really, really, really low. There's no need for a test dose. I mean, this is 2022. I still take these with a grain of salt. We don't use dextran often, but we have some patients that they are not going to come back to the hospital. The only formulation we have in the hospital as inpatient is ferric gluconate. The maximum dose is 125 milligrams per day. If you have a patient that is not going to come back, poorly compliant, you may want to give the low molecular weight dextran. I still advocate on giving the test dose. Now, this study, they show that even giving the test dose, there are no changes between the infusion and non-infusion reaction. The patient had no reaction versus the patient who has reaction was not statistically significant. This is a matter of changing all practices. Based on this, you could just give IV iron with no test dosing. We still do the test dosing. I mean, this is rather new. It's probably a couple months ago. Still, nonetheless, IV iron is safe to use in the vast majority of the patients. Now, this is the evidence that support what I was telling you. You can use oral iron every other day. So what I do is Monday, Wednesday, Friday, and every week, Monday, Wednesday, Friday. So that way, patient does not miss it. Now, it's a very disciplined patient. They have a calendar they mark. They say every other day, and they can take it for several months. They often have a better absorption of iron as compared with a patient who get daily iron dosing. Now, among the patients who get cardiac surgical patients, all those patients who get iron and who respond, they will get the same number of units as the patients who are non-anemic. So IV iron among those responsive patients, they get the same amount risk transfusion. Now, in colorectal surgical patients, there's a decrease of 52% in the blood transfusion, the significant decrease in costs. In orthopedic patients, there's a decrease of 30%, decreased length of stay of 2 days. These among patients who have iron deficiency, who were screened and optimized with IV iron and whose anemia improved. Now, in heart failure, there's a decrease in hospitalization and cardiovascular death among all the patients who get IV iron. It's the ferric carboxymaltose as compared with placebo. Now, when we look at MRI of the heart, there's a decrease in the strain pattern among the patients who receive IV iron. There's way less as compared with the patient who received placebo, which is significant. Now, what the problem, I have told you that when you look at electronic microscopy of the heart in the patient with heart failure who have anemia, they have a decrease in the mitochondrial density. So presumably this is because there's an improvement in mitochondrial density and bare myofibril reorganization in this patient. Now, not everything can always be easy, clean, transparent, it's just so easy, just use IV iron. We had the PREVENT trial that came out, and they basically look at elective surgical patients going for major abdominal surgery. And they found that the use of IV iron versus placebo had no major impact in blood transfusion or death. Nonetheless, from operational standpoint, there's a decrease in readmissions among the patients who got IV iron. And it was even across 6 months, there were less. So this is still some data we still need to do, more randomized trials in larger patient population, and try to compare apple with apple, and remove other risk factors. So what do? I mean, as I told you, I'm not going to fix the genetic problems. The patient already have that. I mean, we can optimize. You can give folate, you can give hydroxyurea, and so forth. Avoid oxidative problems. But I can replete hematinics. I can provide all the substrates to optimize hematopoiesis, iron, B12, zinc, copper, folate. I can evaluate for malabsorption, look for celiac disease, pernicious anemia, small intestine bacterial overgrowth, chronic use of PPI, and so forth. I can evaluate for chronic blood loss, GI blood losses, urinary blood losses, paroxysmal nocturnal hemoglobinuria, so forth. So those things we can evaluate, we can optimize, we can fix. If there is nothing like this, I can refer to hematology and have them look for a myelodysplastic syndrome. We can look for other things and aim to optimize the patient. It's important to analyze and remember that anemia is a consequence of an underlying problem, and we rather find that and treat that rather than just transfusing the patient. Every blood transfusion that we spare is the benefit that the patient gains. So shifting gears, this is a nice segue now for fresh frozen plasma. What about it? Well, it's the most commonly prescribed agent for hemostasis. Up to 60% is not used appropriately. Furthermore, among the non-properly used is the suboptimal use, as I'm going to show you, that is not those based on weight. We have a patient with cirrhosis, INR 1.9, in paracentesis. How many units of plasma do you need to administer? So we need to remember one thing. This graph is really important. If you can get a screenshot of it, will be very wise, and you can share that with your trainees. Just remember one thing. For all the coagulation to be normal, you need to have most of your coagulation factors above 30%. When your INR is less than 2, most of the coagulation factor will be above 30%. When the INR came less than 2, especially less than 2.2 and above, INR is higher than that, then when you start having abnormal hemostasis, because some of the coagulation factor will be below 30%, some will be above 30%, and definitely when the INR is less than 3, all your coagulation factors are less than 30%. This is one of the reasons why in mechanical mitral valve, you really want them to be above 2.5, because then you will ensure that all your coagulation factors are below 30%. Now, in patients whose INR is less than 1.8 and who were transfused plasma, the INR did not correct in 99% of the patients, despite the number of units that was used. Now, in this other study of 7,000 patients, the patients whose INR was more than 2, especially more than 3, those were the ones who have a meaningful correction of INR with plasma transfusion. However, the patient whose INR was less than 1.9, the change in the INR was almost negligible. Now, among the patients whose INR was more than 2, those who received more than 3 units of plasma, they had an increased likelihood of correction of the INR. Why is this important? This is important because plasma must be transfused in a weight-based dosing. Believe me, this is not taught in medical school. This is not taught in residency. And a lot of people do not know how plasma is transfused weight-based. I learned, just give 2 units of plasma, 3 units. Yeah, I give 3 units based on what? Based on just give 3 units. I mean, it's kind of my guesstimate. Plasma must be transfused based on weight. So if you realize a patient who is 60 kilos who get 12 ml per kilo, that's 720 ml. 1 unit of plasma is about 250 ml. That will be 3 units of plasma. This is not 1, it is not 2. Why am I saying 1? Because in my organization, up to 14-15% of plasma is being used inappropriately with single unit, single dosing. And single dosing for the most arbitrary of the reasons. Because patient is going to have an endoscopy, INR is 1.7, and the endoscopy says, I would like it to be 1.5, give a unit. I said, well, that unit is going to make nothing. And so we are providing all this education eventually to eradicate single unit plasma use. Plasma must be given weight-based. Nonetheless, this increases the risk or transfusion-associated circulatory overload. That's why the guidelines rather recommend to provide vitamin K or 4-factor prothrombin complex concentrate. Now, what happens in cirrhotic? Well, cirrhotics are going to have a balance of bleeding and clotting. They're going to have something that will actually promote the risk of bleeding, but there's other factors will promote the risk of clotting. I mean, there's less plasminogen, there's more factor A, there's more factor von Willebrand factor, there's decreased protein CNS. So this is the balance. So the problem is that if you give plasma, you will shift the balance toward procoagulation, and you can increase the risk of clotting. So the guidelines say that paracentesis, these are American and European guidelines, do not recommend for prophylactic plasma before paracentesis. So you will not give any plasma to this patient, especially with an INR less than 2. Now, what about patient who takes warfarin? Well, you rather use 4-factor prothrombin complex concentrate or IV vitamin K. There is no reason to give subcutaneous. I mean, you cannot give oral vitamin K, it's fine. Subcutaneous, but IV is safe to use. Most of the adverse effects are anaphylactoid reaction, not anaphylactic. You can use it safely. I prescribe IV vitamin. Well, way less. Perhaps in the past year, couple of years, most of my patients are taking DOACs. They don't use warfarin anymore. But the patient who takes warfarin and I need to reverse, I just use IV vitamin K with no problem. Remember, patient who takes warfarin, all the blood factors are being actively synthesized. You do not stop synthesis of blood factor. You just stop the final activation. When you give vitamin K, you activate the carboxylate and you activate them rather quickly. And you can see that 4-factor prothrombin complex concentrate correct coagulopathy rather rapidly and immediately as compared with plasma. So this is a patient who needs a IV line, central line, cannot get a PICC line because it's on dialysis. INR is 2. How much plasma can we give? Well, the Society of Intervention Radiology is the one we use at Cleveland Clinic to guide the transfusion and optimization of coagulopathy. And they look for all image-guided procedures, like an A-line, IBC filter, an LP, chest tube, central line placement, a parathora. They don't check for INR, PTT, or CBC. If this is done, INR less than 3 is fine, platelets more than 20 is fine for the procedure. Now, there's a high risk of bleeding, like a deep organ, kind of like a surgery. Well, then will be INR less than 1.8 or platelets more than 50. For a patient with chronic liver disease, when the risk of bleeding is low, they don't care about the INR, meanwhile platelets are more than 20 and fibrinogen more than 100. If the risk of bleeding is high, then INR should be less than 2.5. You would say, well, why 2.5? Why not 2? Because the INR by itself in a cirrhotic patient is not the sole indicator of the risk of bleeding. Remember, there's a balance of bleeding and coagulation. And of course, for this high-risk bleeding, platelets more than 30,000 and fibrinogen more than 100. So in this case, it will be a IR guided line. INR is 2. They will not give any plasma. What about platelets? Well, platelets are expensive. They are stored at room temperature because if they are stored at cold temperature, they clump. Often we do not have enough platelets in the blood bank. they cause vast majority of the transfusion reaction. Platelets are pro-inflammatory, they are not benign. Now, a unit of platelets can be a pool of platelets of 5 or 6 units, will be a pool of platelets, or it could be platelets by apheresis, either a pool of platelets or apheresis. Just one transfusion is going to increase platelet count by up to 30,000. Now, this is how the platelets are presented at Cleveland Clinic. This is the conventional platelet bag. This is when they have a chemoluminescence process that sterilize them and prevent graft versus host reaction. Now, what happened with thrombocytopenia is that we often will see that in the perioperative period. And it is because platelets are going to be activated by inflammation. And you expect a nadir within the first week of surgery. So be mindful there's platelet consumption from inflammation, but also patients can be having blood loss. They can have as infection. They could be connected to extracorporeal circuit like ECMO and so forth. But also hemodilution will play a role, and pseudothrombocytopenia. Pseudothrombocytopenia is something I consider quite often, and the way we do this is that we test for a saturated platelet count so to make sure that that is not the case. So we have a patient that has a prolonged hospitalization, is on dialysis, has fever, has meningismus, has 25,000 platelets, and he's an IR-guided LP. What should be the platelet numbers in order to do this safely? Now, read this carefully. This is an IR-guided LP. A different scenario would be if this is a bedside-guided LP where we don't have imaging. So the evidence for procedure and platelet count, we have found that the risk of bleeding related to the procedure has been actually is not statistically significant among patients who get transfused versus not transfused prior to a central line. So this is one of the most recent studies. This is just published this past year, and it's just, I mean, before this there was no single evidence whatsoever about coagulopathy and the risk of transfusion for central line. So these patients were less than 50,000 with an INR more than 1.5 or APT more than 45 seconds. So this support that if you are doing an ultrasound guided central line, they were able to tolerate it. Now, among the patient who has severe thrombocytopenia, who platelet than 20,000, if they are getting a ultrasound guided, even local hematoma is less than 1% of the cases. And so the use of ultrasound has changes the safety in doing central line procedures. Now, what about lumbar punctures? Well, this is they were rather conservative. This is also a relatively recent study with platelets than 150,000. That's how they define coagulopathy when INR more than 1.4 or APTT more than 39. They basically had no significant change of spinal hematoma. I mean, they could have gone a bit lower, but I can see how the study author would be scared of doing this with a less conservative value. Nonetheless, this is evidence that we did not have before. So in this presentation, this type of talk, version 2019, I had a forbidden sign say there is no evidence. We don't know. So we have to practice according to our. But now we have some evidence that supports a more conservative approach. Now, this is an interesting study among patients with intracerebral hemorrhages that came in an acute way to ICUs in Europe. And they were within 6 hours of the intracerebral hemorrhage, who were taking antiplatelets. They get transfusion to those patients versus standard care. And among both, there was no changes in survival and the modified ranking score, as well as the size of the hematoma. So this is an important thing to acknowledge and appraise. So what do the guidelines say? the guidelines say that if you have spontaneous bleeding, 10,000 should be the cutoff value to transfuse. Central line, 20,000. For a lumbar puncture, 50,000 or 40,000. This is at the bedside with no imaging guidance. 50,000 for major elective surgery or 100,000 for neurosurgery and ophthalmology. Nonetheless, the interventional radiology guideline, they say that for a central line or a lumbar puncture, 20,000 should be okay if you are doing this with IR, interventional radiology. So in this case, will be an IR guided LP, so we should not give platelets. If I would do this at the bedside, I probably would like it to rise it to 40,000. Remember, 1 unit of platelet rises your platelet count about 20 to 30,000. So what I would do is give the unit of platelets just within an hour of doing the LP. So I rise it up, they will be circulating, and then I can do the LP safer at the bedside. But if I'm not going to do it at the bedside, it will be IR, then you don't need to give transfusion. Now there's contraindication. Absolute will be HIT or ITP by all means. Now, as I have told you that for anemia, you can need iron, folate, B12, zinc, copper. What about platelet transfusion? Well, you can optimize von Willebrand factor with EDAVP, especially in the patient with end-stage disease. You can treat sepsis. You can treat the patient that has hyperlipidemia with statin to improve endothelial dysfunction. Manage anemia. You can use thrombopoietin mimetics to increase platelet count. Now, alternative could be platelet transfusion could be use of recombinant factor 7, fibrinogen concentrate, recombinant factor 13, anti-fibrinolytic like tranexamic acid or epsilon aminocaproic acid. So there are other alternatives, especially when patients actively bleeding and we don't have platelet transfusion. I have phone calls from the OR of patients who need, they have active bleeding, they're on the ECMO, and they say, okay, well, have you give factor 7? Yeah, we give. Have you given factor 8? Yeah, we give. Have you done fibrinogen concentrate? Well, we are going to order that. So we have other resources that can be used just when we don't have a platelet available. So we keep evolving. Some people hate these studies. Some people like it. I am on the side that likes it. Thromboelastogram and rotatory thromboelastometry. The chairman of vascular medicine at Cleveland Clinic, Dr. Cameron, he said that this is the most useless test ever. Well, I agree to disagree. The thromboelastography helps to do a geometric assessment of the clot formation. And based on the different geometric parameters, you can find out what you're having. You have a problem with fibrinogen concentration. You have a problem with your clotting factors concentration. You need more plasma. You need cryoprecipitate. You need platelets and so forth. So this is when you can see. I mean, this is you can get that QR. This is from Dr. Nick Mark, an intensivist in Seattle. He has a fantastic group. It's called One Payer ICU. He has the best one payers. I mean, his handouts are superb. He has tens of different topics. Feel free to go to that one, onepayericu.com, or use the QR code. It's very, very didactic. But nonetheless, based on the one payer, you can see that increase our time, you give platelets, decrease alpha angle, cryo, decrease MA, size, platelets, either fibrinolysis, you did anti-fibrinolytics. So I have been telling you about single unit of plasma. This is what's happening in my organization. It's subtherapeutic, it poses a risk for the patient, and it's a waste of product. We are calling, please do not use plasma just to correct the INR. If the patient is not bleeding, leave the patient alone. If the patient is not bleeding, just stop the warfarin. Do not use the plasma just to correct the numbers. Treat the patient, don't treat the numbers. Don't do vitamin K. I mean, you use vitamin K. Don't use just subcutaneous, use IV vitamin K. Use 4-factor prothrombin complex to optimize the glopathy. Don't give plasma for an INR less than 1.8. It's not going to change the INR. It's not going to improve outcome. You're just throwing that plasma to the trash can for some patients really needs it. Therapeutic doses at least 10 to 20 ml per kilo. Plasma is not based on 1 or 2 units, is not based on guesstimates. Plasma dosing is weight-based, 10 to 20 ml per kilo. The adult dose is often between 2 to 3 to 8 units. Underdosing only creates risk for the patient. This is really important. I gave exactly this slide. I took this from a presentation I gave just barely a month ago to the whole Taussig Cancer Institute, trying to support the minimization of single plasma use. Please don't give single units of plasma. We can change our mind. We cannot change anything. This is my email. This is my Twitter account. I will be delighted to answer any of your questions. We have at least 3 minutes here. Thank you for your patience and your time. And thank you for the kind invitation. It is an honor and a highlight in my career to be with you. Thanks.
Well, thank you so much, Dr. Auron. I'm happy to take any questions in the chat, or if you want to ask your questions directly. We have a couple minutes here for questions. This was really very informative presentation, really talking about alternatives of blood transfusion, thinking of all the hemodynamic instability signs, not just the number of the hemoglobin, and thinking about transfusing for plasma in particular based on weight. These are really very important pearls, and since we see it every day, thinking of the preoperative patients, really what kind of alternative that we can provide before reaching for blood transfusion. So very important clinical pearls. Well, thank you, Dr. Auron. Seems that we don't have any questions, and we only have 30 seconds left. So thank you so much, and have a great day. Stay warm there up in Cleveland.
Take care. Thank you.
Bye-bye.
Thank you, Dr. Auron.
Thank you. Take care.